Hey everybody, welcome back to Perinatal Bloom, or if this is your first time here, welcome. On this channel, we unpack everything birth and beyond. In this series, I am focusing on differences between sort of the US health system and the NHS, specifically as it pertains to giving birth. So from pregnancy through the birth, through the early postnatal period, as well as some later postnatal and postpartum visits, support, etc. So welcome, whether you're just curious and looking around, whether you're preparing for your pregnancy journey abroad or here in the UK, whether this is your first baby or you've recently welcomed a baby, listen in, learn, share, subscribe, and I'm very happy to have you here. So newborn screenings, NIPE, SATs, jaundice screen, blood spot test. What does all of that even mean? When is it done? Why do we do it? Who does it? You're going to learn all that and more in this video today. We're going to talk about the top 5 newborn screens that are done routinely for everybody who's born either at home or in a hospital, but within the NHS system. Privately, this is an entirely different conversation, and I'll make a video on that another time. And then we'll also talk about some additional screenings that may be necessary for your baby with some specific risk factors. And finally, we'll talk about 3 other types of kind of health checkups that we might do for your little one to make sure that they're as healthy as can be. Please remember that the information presented in this video does not constitute diagnosis, medical advice, or treatment of any symptom or condition and is for educational and commentary purposes only. So the first of our kind of main common newborn screenings is going to be a SAT screen or pulse oximetry. This is where we're going to be looking at how they are oxygenating, so sort of measuring the saturation of oxygen in their blood. And this can be really indicative for congenital heart disease, and this can also show us early signs of infection or other signs that baby is unwell, not breathing well in the outside world, and may need some extra support or further testing in the NICU. So for the pulse oximetry test, what we're going to do is we're going to put 2 little probes on the baby, one at a time. The first probe is typically going to go on their right hand, and we're just going to put it around their little hand, and it does tape down to stay in place. And then next time what we do is we're going to put it on either one of their feet. And what we're looking for here is we're looking for good oxygen saturation levels as a first indication of good well-being. Typically, we would like to see them sitting well above 95% oxygen saturation. But the second thing that we're looking for is the difference or percentage difference between what we find on their hand and what we find on one of their feet. And ideally, we want to see a less than 3% difference in those 2 readings. And that tells us that baby's heart is likely working well. There's unlikely to be any sort of significant congenital abnormalities or disease. Of course, like any testing, this is not 100% foolproof, and there are other screenings that babies are going to have that, again, are going to take a look at their heart well-being. But this is one of the first steps that we can take to ensure that baby is doing well overall, that their heart is working properly, and that we're not necessarily seeing any early signs of infection or any sort of deterioration from your little one. SATs testing is most commonly going to be done by a MCA or MSW, so maternity support worker that's helping along the midwife. It may be done by a midwife, or again, if it's being done at home, because of a home birth, it will be done by either the delivering midwife or any support team like a home health visitor. But most commonly, it will be done by an MSW or midwife in the hospital and midwife at home. Test number 2 that your little ones are going to have in the hospital is going to be a routine hearing screen. Typically, this is going to be done within the first day after birth. On average, sometimes there could be a slight delay, but typically this is something that we'd like to do in the hospital before you are discharged. Now, if your baby is born in a home setting, that this is likely something that your community midwife or home health visitor is going to do, or they may refer you to a hospital or to a GP practice to get this done. But ideally, we do want to get this done early on, and especially if for whatever reason baby doesn't pass the initial test, we may need to do a repeat one within the next couple of days or within the next week or 2. So this is something that is ideally done quite early after birth. So it's a very simple test. It's very kind of non-invasive. It doesn't hurt the baby. It doesn't really alert them or bother them. But essentially what we're going to do is place a little probe on their ear, and there's going to be these little clicking sounds, and we're looking for a reaction from your little one. Most babies do just fine. They react to both sides and they pass their test, and you have those results immediately. And then for some kiddos, they may only react to one side instead of both, or sometimes they may not react at all. this is not an immediate indication of, profound or permanent hearing loss. This could just be environmental. Sometimes this happens if a baby was recently unsettled or crying really hard or really, really upset. This could be because the environment is really loud, or maybe they're starting to fuss and get really, really hungry. Or conversely, they've just had a nice, good breastfeeding session or nice, good full meal, and they're now completely conked out in their little cot and just not interested in anything that's going on around them. That is also not an uncommon reason for them to not pass that first test. So if that is the case and they don't initially pass their hearing screen, we may repeat it while you're still in the hospital. We may repeat it as a home health visit once you've been discharged, or it's possible that you may have it repeated at a GP practice, general practitioner, when you go to get your baby checked out in the next couple of weeks. So, test number 3, the NIPE. The NIPE, or the Newborn and Infant Physical Examination, is something that was formally launched in 2008 and was also revised in 2019. But this is a national sort of program in order to make sure that we're screening kiddos early on for any potential health concerns, and in particular that GPs and midwives are able to take a nice close look at the kiddo in a systemic and holistic way. So usually when an NIPE is being performed, it's part of a larger just kind of checkup on the baby. So we're taking a look at them head to toe. We're making sure that they're looking healthy, that their breathing is looking fine, that they're not struggling to breathe, that they're making normal sounds, that their tone looks fine. So kind of their muscle, making sure they're not looking floppy or anything like that. But additionally, the NIPE looks at 4 specific areas of their body to make sure that, again, they're as healthy as can be and that we're catching any potential long-term illnesses or disabilities early on. So the first is going to be the eyes. And in particular, what we're looking for here is not a vision check. We're not going to be able to do that until they're a little bit older and can tell us letters or shapes or numbers or whatnot. But instead here, we're taking a look to make sure that they don't have cataracts. I've included information on the eye check that is done as part of the NIPE examination, linked below this video. But essentially what we're doing is typical to what we do when we look at adult eyes, is shine a little light and take a look at the overall health of their eye. The next is going to be their heart. So typically, we're going to keep an eye on baby's heart rate. For some kiddos, it might be a one-time set of observations. I'll talk about that at the end of the video. For other kiddos, it might be a more regular set of observations depending on their risk factors. But during the NIPE examination, what happens is the midwife or GP, depending on when this is being done, they're listening specifically to their heart. Yes, they're looking at their pulse and making sure that it's within normal ranges and that it's pretty regular, but they're also listening for any heart murmurs. Some kiddos are born with a murmur that resolves completely on its own and is not an indication of any sort of illness. And other babies may have a heart murmur that is actually indicative of kind of more significant heart disease. And depending on the severity of the murmur and other findings, including that SATs or pulse oximetry that we do in the first day, that could be an indication of sort of additional testing being necessary, or maybe going up to the NICU for some closer monitoring. Most kiddos don't need this. Their hearts sound just fine. And, at that point, they're either at home or getting ready to be discharged. But occasionally, this is a way that we might catch some of these abnormalities and require further testing. Area number 3 included in the NIPE that we take a close look at is going to be their hips. In particular, what we're looking for is what's called DDH, or developmental dysplasia of hips. And essentially, we want to make sure that their hip joints are moving properly because occasionally, depending on how they sat in utero, how the labor went, what method of birth they went through, there could be some damage to their hip joints. And if this is not caught early enough, those kiddos can actually grow up with that hip dysplasia and have challenges throughout their life, including a limp or significant mobility issues. So again, this is something that will be looked at as part of that NIPE examination. And if further testing is warranted, they will let you know and they will connect you with specialists and services to do that. For most kiddos, they do just fine. They're not a big fan of this one because we're sort of maneuvering their leg and moving them around a little bit. So sometimes they might get a little bit fussy during the exam, but this is not typically an indication of pain. It's just more so that a stranger is maneuvering their body when they're just trying to rest. So you may find that your kiddos are not super happy during the NIPE examination, but this is not typically an indication of pain or discomfort, just more so the fact that they're kind of unhappy that we're doing this. And then finally, if you have a little boy, then the fourth thing that is going to happen is an examination of their testes to make sure that we're not missing a potential undescended testicle. In particular, this is the one that really does need to be repeated at the 6 to 8 week mark, because initially it might be difficult to catch at that initial newborn NIPE. And so when we repeat it at the 6 to 8 week mark, when they're a little bit bigger, a little bit older, we would expect to see some progress. And if we're still seeing challenges with a potentially undescended testicle, further testing may be required, or this may be information that the GP is going to follow through their childhood to see how they grow and develop. Typically, the NIPE is done for the newborn around the 72-hour mark, so around day 3 after birth. And for our infant, it is typically repeated around 6 to 8 weeks after birth. So depending on your birthing center, so whether you gave birth at home or in a birth center that's attached to a hospital, or if you gave birth on a delivery unit and are now on a postnatal ward, this may be done either in a home setting or in a hospital setting. So if you are still in the hospital, this will probably be done by a NIPE specialist midwife in the hospital. And then if you are at home, this may be done by a NIPE specialist midwife or potentially a health visitor, which is usually a nurse or somebody who's very, very trained in kind of all things newborn and specifically in NIPE. And so this may be done in a home setting at that 72-hour mark if you've been discharged or if you gave birth at home. The 6 to 8 week checkup is usually going to be done at the GP or general practitioner's office. We talked in this video about the various providers that are going to be involved in your birth and postnatal care. And one of the things to be aware of, again, is that in the UK, pediatricians are more specialized and they're typically not seen unless there's some additional concerns going on with the baby. And for typical routine checkups, immunizations, developmental checkups, your baby is going to be seeing a GP or general practitioner, which is similar to a kind of internal or family medicine doctor that you might see in the US. Like all other screenings, the NIPE is a elective screening in the sense that you're not required to do this, by the government. Nobody's making you do this. Nobody's going to tell on you to, social services or safeguarding if you don't choose to do this test. But it is something that is highly recommended, and it can be really helpful in helping to catch certain lifelong diseases or disabilities early. I found a really interesting study that I wanted to share with you. It's linked below, but basically what this looked at, it was a qualitative analysis of parents' sort of interest or willingness or their feelings around this study. It is a small sample. It's only about 16 parents that responded, and obviously it is a qualitative sort of opinion study. But basically what they found that even experienced parents did find this type of examination helpful. They found it reassuring. They felt like it gave them an opportunity to ask questions and to really know what's going on with the health of their baby. And so they really appreciated the information and found reassurance in what the NIPE examination provided, particularly at the 6 to 8 week mark. So again, it's completely up to you whether you decide to do this or not, but we highly encourage you to do so, and more information is linked below. All right, screening number 4 is going to be looking at jaundice. So this is something that we're informally looking at from the very beginning. So even within the first day after baby's born, we're going to be looking at their overall eye color and skin color and any potential signs of jaundice. Another common sign of jaundice is going to be if their pee is really, really concentrated and yellow. So we're maybe looking at their diaper output as well, just to sort of see if it's looking normal. For newborns, usually urine is going to be pretty clear if they're well hydrated, but it might be that kind of darker, brighter yellow color if there's any concern with their intake, which is one of the things that can contribute to jaundice. And then usually around day 3, so again, around that 72-hour mark, we are going to go ahead and do the little skin test. So it's just a little scanner that we put either on their chest or on their forehead. We just hold it there and it scans baby's skin and measures their bilirubin. Now, occasionally, if that comes back quite high, we may encourage some feeding and then recheck it, or we may need to do further blood testing and potentially have the kiddo go on the blue light therapy, which may be done right there at your bedside with a cot blue light, or they may need to go to the NICU in order to do a more overhead and comprehensive blue light therapy. But again, most kiddos don't need this as long as they're starting to take in some breast milk or feeding in those early couple of days. They're going to start making some output, breaking down that bilirubin, pushing it out of their body, and their bilirubin levels are going to be just fine. If your kiddo has already gone home before that 72-hour mark, then your home health visitor or the midwife that's seeing you at home is going to do that jaundice test, again with the little portable scanner. And if you start to notice any yellowing of the eyes or skin, or you have concerns about baby's intake or output, please don't hesitate to call your midwife and potentially come back to the hospital to be seen, or have them schedule a visit to come check your baby out at home. And common test for newborns number 5 is going to be what's called the blood spot test. I know it sounds very ominous, but really it's very, very simple. And in the UK, this test is something that tests for 9 specific abnormalities, genetic abnormalities. And I've linked those below this video for your information, and you can read up more on them if you'd like to. In the US, this is also something that's very similar. It's often called genetic screening or a heel stick test. Most states will mandate this as part of the kind of early newborn care, and different states will test for different amount or types of genetic abnormalities. But in the UK, under the NHS, we're usually testing for a specific 9, and you're going to typically get the result to be a male. And what's going to happen there is one of 3 types of results. Either there's going to be no indication or baby is not a carrier. Result number 2 may be that baby is a carrier, but they don't currently display any symptoms. At that point, it may be something that is followed closely by the GP, but is not necessarily requiring any further testing at this time. And result number 3 may be that there's evidence of this disease, which means that yes, baby's a carrier, and they're potentially, needing more testing in the more urgent sense, and may actually require treatment immediately, depending on the type of genetic disease that it is. The way that this is done is very, very simple. We're going to take a tiny little needle and we're going to prick usually the side of baby's heel. I know I'm showing on my hand, but it's actually going to be on their foot. And we're going to get just a couple of spots of blood and a very specific piece of paper that is saturated with some additional chemicals. And then that is going to be sent off for testing. Usually that little card is kept kind of on hand in the laboratory for about 5 years. And this is done in case repeat testing is necessary, and also to sort of follow trends of genetic abnormalities and kind of what we're finding. If you would like that destroyed sooner than that, you can definitely let your GP know, and that is something that they can contact the testing facility for you and get that done. But generally, most people don't mind. It is obviously kept very confidentially, but typically it is kept on hand for about 5 years and then destroyed. Blood spot tests may be done in the hospital by a midwife, or it may be done at home, given the fact that it's usually done around day 5. A lot of us have already been discharged from the hospital and are settling into life at home. So at that point, it may be done by a midwife or home health visitor that is coming to see you in the comfort of your home. Most babies don't mind it at all. Personally, when I had my daughters done back in the US, she slept through the whole thing. But most kiddos don't mind it at all. Some may fuss a little bit. It might be good to give them a little cuddle, or maybe even offer the breast immediately after the test in order to help them settle down. But generally, it doesn't bother them one bit. It's nice, easy, and straightforward. So now that we've covered the 5 main types of newborn screening that every baby is going to get with your consent, there are 2 additional ones that some more at-risk kiddos may need. The first is going to be blood sugar testing. So this is when we're doing a little bit of a prick and we're getting a drop of blood and we're testing their blood glucose levels. This may be indicated in a couple of instances for our babies. The first and most common one is going to be for any baby that is born to a parent who has either gestational diabetes or is a diabetic sort of generally throughout their life and not just in pregnancy. This automatically puts baby at a higher risk for fluctuating blood sugars, so they will typically be tested for blood sugars. The frequency is going to depend on each individual case. A lot of times they're tested immediately after birth. A lot of times we may do a fasting, so kind of a before feed and then immediately after a feed, or an hour after a feed. But this is going to vary from kind of baby to baby, depending on the circumstances and the reasoning that we are testing them. Another reason may be if a baby is born to a parent who is on beta blockers or certain types of blood pressure medications. Those can actually affect baby's blood sugar levels. And so this is where some testing may be necessary immediately after birth, just to make sure that baby's blood sugar levels are staying nice and stable. And then finally, if there are complications with a delivery, or if a baby's born in poor health and we can kind of tell that they're unwell, or maybe they required a little bit of assistance early on, or maybe a little bit of resuscitation, that may be one of the tests that we do as well to make sure that everything is as stable as can be. Again, this is not going to be done for all babies, but the most common reason would be somebody who gives birth and they had gestational diabetes, or they are a diabetic in their life. This would necessitate the baby to be tested for blood sugars. This is something that you will be told about in your pregnancy. So depending on if you develop gestational diabetes or if you're generally a diabetic, this is something that you will already know about. It will be reiterated after the baby's birth, and we will always gain consent before testing. But this is definitely one of the ones that they're going to encourage, just because blood sugars in a newborn baby are incredibly important to be kept stable. The more the blood sugar drops, the more other health concerns can pop up, and that baby can deteriorate very quickly. So we want to stay on top of it and keep them well leveled and know what's going on with their blood glucose levels. The other potential tests that we may need to do are cord blood gases. And this is something that may be done for a baby that is born in really poor condition. So they're just really, really unwell when they're first come out into the world. Or if it was a complicated birth, or if it was maybe like an emergency C-section because mom and or baby were deteriorating very quickly. So this is a situation, again, that most of you will hopefully not encounter, but this is another sort of common high risk or high complexity test that we may need to do for a baby that's born in less than ideal circumstances or in less than ideal looking health. The blood sugars testing may be carried out by an MSW, maternity support worker, or by a midwife. Very rarely they may be carried out by a delivering obstetrician, but majority of the time it's going to be either a midwife or a maternity support worker. And then typically the cord blood gases are going to be collected by a midwife or potentially the delivering obstetrician. But again, it will vary from situation to situation, but those are usually going to be the people involved in this testing. So the routine screening that we've talked about, as well as some of those more rare but more complex screenings, are not the only way that we're checking on babies' health during their time in the hospital, as well as those early days at home. One of the things that we're going to be doing for baby are what's called OBS, or observations, which is another word for vital signs. So this is something that may be done for a baby just once, if that is a perfectly healthy or what we call green baby. We may be doing it on a more frequent basis for a baby that's maybe had some challenges during the birth, or maybe their blood sugars aren't super regulated, or maybe there are other health concerns with the parent, and therefore we want to keep an eye on the baby. And commonly, these are going to be our amber or orange babies. And then finally, we may do even more frequent ones, like say every 2 hours, for what we call a red baby, or a baby that is not doing very well on the outside world, or maybe had a very challenging delivery, definitely has blood sugar issues, and maybe some other concerns that we're seeing, including jaundice and things like that. So what does this entail? It's very simple. It's very non-invasive. It may be done by a maternity support worker or MSW, or it may be done by the midwife in the hospital setting. But typically what we're going to do is we're going to listen to baby's heart rate. We want to see a certain number of beats within a minute. So we're going to listen for 1 minute. There is a somewhat wide range of normal. Typically we want to see between about 100 and 160 beats per minute. But we want to make sure that it's also staying nice and consistent the few times that we're checking, especially if it's an amber or red baby that we're checking more frequently. We're also going to listen to their breathing for a minute, and we're going to count the number of breaths, but we also want to make sure that we're not hearing any gurgles or any difficulty with their breathing. So we want to make sure that they had a chance to expel that fluid out of their lungs and they're breathing effectively on the outside world. Temperature will be the next thing that we're measuring. Most kiddos are very unhappy about this. All we're doing is sticking a little temperature probe underneath their armpit, but they're very, very unhappy, and most of them will fuss and cry during this particular time. We do have what we call kind of a Goldilocks or a sweet spot zone range where we'd like their temperature to be. And any baby that is measuring particularly warm, this could be a sign of a fever and potentially infection. And any baby that is measuring well below that, this is going to be a concern for maintaining their blood sugars, because as soon as baby's temperature drops, they're having to burn a lot of glucose to try to bring it back up. And this is a very, very big concern. So at that point, we may do some more skin to skin or layer them up or look at what might be causing their temperature to be that low. But typically, this is the part that they really don't like of that OBS set of observations that we're doing. When we're doing these OBS, the other things that we're looking for are their tone and their behavior. So generally, we want to make sure that they look nice and pink and that they look normal, that they're not sort of, floppy, that we're not seeing any grayish or bluish skin, and that they're generally behaving the way that we would expect a newborn to behave. And behavior-wise, is that baby waking up and alert when we start messing around with them, when we start doing these OBS, when we're starting to maybe stir them a little bit, when we're taking that temperature? If that baby is completely floppy and unresponsive, this is a huge risk. This is going to be probably an emergency. We're going to call a lot of staff in to come and help us to figure out what's going on. But for most babies, they are going to be very alert, even if they're sleeping soundly as we're listening to their heart and their breathing. As we start to undo their little onesies or vests and start taking their temperature, they're going to get very fussy, very alert, and that tells us that baby is reacting normally. So those are the things that we may be looking for under the set of OBS or observations. And we will likely be doing this once for a green baby, about every 4 hours for an amber or orange baby, and probably every 2 hours for a red baby. These designations will be explained to you. We will tell you why we're putting them under the specific category or designation, what concerns we have over them, and how long we need to do these OBS or observations before we can step them down and stop doing them. Another common way of looking after baby's health and knowing that they're doing what they're supposed to is going to be their weight. This is very similar to what you might expect from newborn and infant checkups in the US, but the NHS does dictate sort of the frequency of those weight checks and how they're done and where they're done. So typically we are going to get a weight on the baby after birth, and we just want to get kind of a baseline established of what is their birth weight. This is going to be very, very similar to what we do in the US as well. From there, we will usually weigh them in the first couple of days, which may still be in the hospital, usually day 2 to 3, or this may be at home if it's maybe done on day 3 or 4 once they have gone home and you've been discharged. What we're looking for here is there any sort of weight drop going on? It is not uncommon for newborn babies to lose a little bit of weight, but we typically want to see that being quite slow or gradual. And eventually, by about 2 weeks old, we would like to see them come back to their birth weight. So a lot of times, especially if we see a drop off happening with baby in those first couple of days, we will do another weight check around the 2-week mark, probably in your home with a midwife or home health visitor, in order to make sure that baby has come back to their birth weight. And then from here, they're going to start growing and packing on those pounds. Once they have returned to their birth weight, the NHS says that we should be measuring them once a month, no more than that, unless there is a significant concern with their feeding or intake or other health issues. But as long as they're looking healthy and developing normally, we should weigh them no more than once a month until they're 6 months old, and no more than once every 2 months between 6 months and 12 months old. This way, we're not looking for problems where we don't need to, but we're also keeping a steady eye on their growth and making sure that they're staying on their centiles, as they're called in the UK, or growth charts or percentiles, as we call them in the US. So basically, we want to make sure they're maintaining their growth trajectory. They are putting on those pounds, but we're not checking too frequently or too rarely, and potentially, finding problems when there aren't any, or potentially missing some important information about their growth. These can be done with your home health visitor. This can be done if you see a lactation midwife. This can be done at your GP's office at your baby checkups, or you can just schedule an appointment for a weight check if it's been a while since we've checked them. But this is something that will be regularly done to keep an eye on baby's growth. And then finally, while you're still in the hospital, and this is absolutely something you should consider at home, but while you're still in the hospital, one of the things that we will ask you about is baby's output. In particular, we want to make sure that they're making wet diapers, or nappies as they're called in the UK, because this is going to tell us that they're taking in what they need, and that also that their urinary tract system is working well and that they're properly hydrated. Sometimes we may ask you to show us one of their nappies to make sure that urine color looks normal. Like I mentioned earlier, it should be clear or very, very pale yellow. If it's brighter yellow, if it's really kind of saturated in color, that's going to tell us that something's going on and sort of send off some red flags that we need to look into them further. But we'll also ask you about their bowel movements. So usually in those first couple of days in the hospital, whenever we come to see you and baby, whenever we're checking up on you, providing any sort of support or education or care, we will always ask if baby has had any more wet or dirty nappies. And if so, how many? Would you say that it was nice and full? Did you see any concerning colors? Anything along those lines. All of the results from all of this various examinations, testing, weight check, etc., is going to be recorded in your baby's little red book. So this is something that is going to be given to you at the time of birth in the hospital. Some trusts are getting away from a physical red book and are actually now changing over to this app here. Some trusts are still using the physical book, and then parents choose to transfer that information into the app as well, just to sort of have an e-record in case something happens to this book, you lose it, house catches on fire, flood, etc. Never know, life happens. But essentially, we're going to record all of baby's important information in here. This is also going to include their growth chart. So as we're keeping an eye on that weight gain, that information is going to go into the red book. And then also at any GP visits or home health visitor visits or midwifery visits, anything like that, once your baby's here, all of that information will be recorded in the red book as well. You can also keep track of baby's illnesses, any sort of medications that they're prescribed, whether temporary or, on a regular basis, and any sort of developmental concerns or milestones that you feel are important. You can jot it down in this red book or include it on the e-red book. And that way, at your next GP visit or your next checkup with your midwife, you can bring up your concerns or share what you've noticed with baby in the meantime. Thank you so much for joining me today. I hope you found this information helpful. There's additional resources linked below, and then please feel free to share this video with any friends or family that might benefit from this information. If you would consider subscribing, I would really appreciate it. It would really help my channel along. And I can't wait to see you in the next video. And again, thanks so much for visiting Perinatal Bloom. Let's bloom together.